Okay, thank you all for joining today, and we're going to get started tonight. We're going to go over our PCCC educational night for this quarter is on cannabis use in older adults, considerations and care. You'll hear the term older adults and elderly used interchangeably. The original term was elderly. And recently in the long-term care field, it's actually been updated to use the term older adults, as 65 and older would be considered in this age group. So please feel free to send info on to post in the chat about yourself or where you're coming from. Post any questions, and we will get to those at the end. And we're going to actually start off with Dr. Paul Loffel. And then we're going to go to myself. And again, we're presenting for the Pharmacist Cannabis Coalition of California. And we are a nonprofit organization. And we try to put on educational presentations about medical cannabis at least every quarter, if not more often. And we would love to hear your feedback as well as information about other topics you would like to hear on. So go ahead. Oh, let me just mute people. Hold on one second. Guys, just please make sure you keep yourself muted just to make it easier. And I will try to do that. So I'm going to go back and go ahead, Paul. You are set.
Okay, well, let's have the first slide. You've seen this disclosure or heard it from Dr. Leah. I'm a clinical pharmacist associated with Golden Gate Pharmacy in Novato, California. That's in Marin County. We are a long-term care pharmacy and also heavily embedded in the psychiatry world. So next slide, please. So the question we raised tonight is, your mother calls you on the phone and says, I'd like to use drugs. What should I know about them? And furthermore, I'd like to use cannabis. And what should I know about the use of cannabis? So we want to talk about the older patient today and give you some general guidelines. I might point out that probably 50 years ago now, I was involved with USC and their gerontology program, and we did some work in the elderly side of the world. I personally dealt with over-the-counter drugs, and others dealt with prescription-type drugs. And so a lot of my education came very early on as we began to look at who are the older adults and what should we know about them. So, for example, starting at age 30, you lose 1% of your renal function per year. So you can therefore understand that in terms of metabolism and disposition of any drug, renal function is going to decline, which means that your blood level should increase, at least somewhat, over time. Second of all, calcium absorption declines, leading to fractures more often in women than in men, probably because women's bones are less dense than men, and men can take the effects of falling easier than women can. The other issue is that we have a number of things that happen to us that we need to have replaced. And it could be from an anatomical standpoint, like new knees, new hips. What about cataracts? What about hearing aids and so forth? Or we could be using drugs to affect various functions in our body, such as diabetes and glucose control, or hypertension as it relates to vasoconstriction, or COPD, as we have been exposed to various environmental toxins, perhaps nicotine and smoke. So those are all issues that affect and accumulate in the older adult, leading to the conclusion, frankly, that older adults take more medicines than younger adults, at least 3 to 5 medications per person over the age of 65. And so that's another drug interaction question that you should be concerned about. Next, please. So some of the issues that are associated with these, for example, heart failure is more common in the elderly due to either a failing muscle itself or rhythm changes. And so we're talking about atrial fibrillation or the effects of an MI. Hypertension is usually caused by vasoconstriction, and because of that effect, in order to treat the disease, we usually give vasodilation type drugs, either directly on the vessel or indirectly through the kidney and the renin system. Skin changes you're likely to observe if you observe photographs of your family or others. Dry skin, may have cancer, wrinkles being developed, and so forth as we age and we lose our fat pads. The most common medical issue in the elderly is arthritis. In the days that when I first looked at this, 38% of the population said that that were over 65 said that they had issues with arthritis, aches and pains of whatever you type or directly associated with effects on bone. This might lead you to think therefore, is cannabis useful in pain? And if it is, again, over 30%, approaching 40% of our population is going to need some kind of pain help. Lack of mobility and resultant falls also occur. And this is the result of aging and lack of coordination and ability to maintain one's balance. Tiredness and fatigue also occur in the elderly, perhaps dealing with the decrease in hemoglobin and the lack of production of red blood cells, leading to fatigue as one of the issues associated with the elderly. We do know that the elderly tend to sleep more, and this might be a marker of that. Next, stress due to health conditions and or finances may be an issue dealing with the elderly as they try to cope with inflation, cost of medical care, cost of food, cost of rent, all of those kinds of things. And lastly, and actually more importantly, from a respect of arthritis, the decline in sensory organs, whether it be eyesight or hearing, is fairly significant in this age group. So be aware of that activity also. Next, please. So if your mother calls you and says, what can I do if I'd like to take some cannabis? And what would your recommendations be for your mom or other elderly folks that you may consult with? So Dr. Leah Johnson is going to take over from here and talk a little bit more specifically about cannabis and its effect on patients who are older. Leah?
Hold on.
Thanks so much. Hold on one second. I'm actually just going to stop the recording and so I can stop sharing and then reshare. Hold on one second. Okay, so on to the next section. Can everybody see the slides?
Yep.
Yep. Is that nope or yep?
That's a yes.
Okay, thanks, Jill. Okay, so we're going to start with a brief history of where cannabis even came from. So why are we even looking at this? Where did this even come from? Why are we even considering it a therapy? So it actually started with hunters and gatherers, and they would actually consume the raw flower. There was a lot of questions about why they started doing this, and what they found is that there was a lot of the same reasons we use it today is another reason why they probably used it back then. Now, raw flower doesn't contain the decarboxylated cannabinoids. So it would have THCA, CBDA. It wouldn't have the THC or CBD. And there's questions, there's speculation on if the body can actually convert it when ingested. There's science back and forth on that. But overall, the reason hunters and gatherers were using the raw flower was for the PTSD of the trauma of having to go out and seeing your colleague, your fellow hunters getting impaled when during hunts, and all the violence and all that, as well as for natural healing and pain therapies as well. So from the early, after that, cannabis use as a general use back in the early settlers was actually reduced from using it as from the actual humans using it. And it ended up that the early settlers actually were using it, cannabis seeds specifically, as supplement feed for their animals. During this time, we noticed that there was a lot of human children dying during this time. However, the cattle and the other animals seem to be doing pretty well, and their young were staying healthy. So the early settlers thought to themselves, well, why are our babies not surviving and why are the animals surviving? And really the only difference was this cannabis seed that was being given to the animals. So they actually started giving the cannabis seed to the babies, and they actually started thriving and not dying as easily. And what they realized is that there was essential fatty acid oils in the cannabis seed that the children were missing out. And these essential fatty acids were what they needed to survive. Going a little farther, it was the first time it was actually documented in history was actually with Shen Nung, who utilized ma, that's what they referred to as hemp pretty much back then, and for its medicinal compounds for gout, malaria, and constipation, and there's many, many more. So down here is actually a rendering of what Shang Nung probably looked like. And again, they consider him the original father of documentation, pretty much, of the use of medical cannabis. So that's where it came from in history. So this isn't a new therapy. This is actually a therapy that's been used all the way back to our hunter and gatherer times. Okay, so now that we've gone over a little bit about the history, let's take a very, 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 very short, brief look into the endocannabinoid system. So what you will know is what you should know is the endocannabinoid system is actually throughout our entire body and actually regulates the signaling and messaging for the other systems in our body. Often you see THC working in the negative feedback loop to downregulate transmissions of sensations to make sure that the responses are reduced. So that is one way it's helpful. That's one way that it's seen to work in the body. So let's just go over the basics of the endocannabinoid system. We have three main components. They are the cannabinoid receptors, the endocannabinoids, and the enzymes. So cannabinoid receptors are how cannabis actually works in our body as a therapy, because we actually have receptors where the cannabinoids can bind to it. Now, mind you, there are a lot of cannabinoids that are used that can act as an allosteric modulator and can modulate on other receptors, but that we do specifically have cannabinoid receptors, and especially THC will bind pretty easily and strongly to the cannabinoid receptors. We have cannabinoid receptor CB1, which is mostly found in the brain and in the nervous system. However, it can be found really throughout the body, and then also for the CBD, for the CB2 receptor, that is found more in the periphery of the body. So again, these could be found throughout the body, but it's mostly seen in the nervous system or in the periphery. And you can see that here on the diagram with the light grayish color. As you can see, it's mostly in the central nervous system. And then with the darker color, you can see that that's more in the periphery, other side of the body. But again, you see both throughout the body. So endocannabinoids. So the reason why cannabis even works in our system, besides the cannabis, or the reason our system readily accepts cannabinoids as medicine, is because we have endocannabinoids. What endocannabinoids are the cannabinoids our own system makes. So the way that so they get processed, and what happens that we find is that over time, with stress and just body breakdown, especially in the older adults, we're finding that the endocannabinoid production is actually decreased. So I like to kind of explain endocannabinoids and cannabis use similarly. Again, it's not the same, but similar to insulin and replenishment of insulin when the body is either not making any or not making the right type to properly work. So the same thing with cannabis is when the endocannabinoids are not producing enough, you can take cannabis, which will help to replenish what the body's not making. It doesn't work exactly the same by any means as the endocannabinoids, because the endocannabinoids actually are fast on, fast off the receptors, and they get broken down very easily by FAAH, which is the enzyme that breaks it down. So we want to make sure that, so the importance to know is we do have endocannabinoids. Our body makes endocannabinoids, hence endo, for the function and to make sure all of our other symptoms in the body, and as you can see, it's throughout the entire body, to make sure the functioning of all the other systems is correct. So the cannabis is helpful when we're not making enough of our endocannabinoids. And again, the enzymes, we have enzymes in our systems that do break down the cannabinoids. And for example, as I was mentioning, there is FA. So the endocannabinoids are the two common ones are 2-AG, and that we say the structure, the 3D structure of the molecule is actually very similar to CBD. And the same thing with anandamide. Anandamide is actually called for the bliss because in Sanskrit, ananda means bliss, and that's why they named the THC named it that molecule for our endocannabinoid. And when you see the 3D structure, and I actually have both right here at the bottom, you could see that the anandamide and the THC actually have very similar 3D structures, showing how the binding works at the receptors. So again, very brief. There's lots to know about the endocannabinoid system, but we do not have time to go through it all. So some pre-work we need to do with our older patients. This actually is pre-work we should be doing with all patients, not just older adults, but especially for our older adults. We want to make sure that we're reviewing all their documents, making sure that we're getting their current labs, their current blood work, past medical history, current medication, so on and so forth. I don't need to read you all, but we need a full comprehensive review. This is really important to check on medications that can be inappropriately used or medications that are missed that are needed. It could also show you different herbal supplements or different herbal supplements as well as different normal supplements, medicine supplements that have issues that either should not be taken or are being missed. And again, we should also make sure to have a questionnaire to learn more about the patient's past use with medical cannabis or cannabis in general, because once we know how the patient responds to it, cannabis is a very touchy drug, and every patient, the dose is based on the patient, not on the ailment like we see with regular pharmaceuticals. So we really need to, as always we say, is we always start low. We increase the cannabis slowly, and we stay on the lowest effective dose. So by knowing what cannabis the patient has used in the past, it really helps us get an idea of where we should start and what cannabinoids have worked in the past. And then again, we're going to want to do a full consultation. And the biggest thing with the blood work, especially for cannabis, is the LFTs and LFTs, because the AST and the I believe AFT, and my brain's not working right now, but the LFTs need to make sure that they aren't getting elevated. And we see that a lot with CBD, but we also see that with cannabis in general. So we do want to make sure we're monitoring them, because if the patient already has elevated enzymes or is already on other meds that could run that risk, we do want to make sure we monitor the patient for it. Okay. So after we do our overview, let's go into general knowledge of cannabis for different ailments. So I have a bunch of ailments right here. It's been approved for all of these many different ailments, but usually in elderly, the patients I see, I've worked with patients on hospice a lot. I've worked with patients with cancer. I've worked with patients um, with Alzheimer's and dementia, as well as anxiety and insomnia. Insomnia and Alzheimer's and pain are actually the three biggest ones I see patients for. So again, huge, wide range of uses. And again, it works because it works on the cannabinoid receptors and helps with a negative feedback loop. So that's why it's helpful for many different ailments. And that's why it's very important to focus on the patient when treating them as opposed to a specific dose that you want to use. Um, it's important, again, the point of using cannabis is not to really treat, it's to bring the endocannabinoid system back to homeostasis. Pretty much your endocannabinoid system, when it has dysfunction, the effect of it gets reduced. So you want to make sure you're taking the cannabis to help you bring you back to baseline, technically, of where you should be normally. So again, the goal of medical cannabis is never to have the high. The euphoria is really not what we're looking for. We're really just looking for the treatment of the symptoms the patient is having. And these ailments specifically here were approved by the California Department of Cannabis Control. So I go to the next slide. So let's go into more information about really the different methods that patients can use. We know there are many different methods out there, and we do have inhalation. By inhalation, we mean smoking, whether it's through a pipe or a different device. That is specifically smoking. There's also vaping, which is heating the live flower, to a certain level, but not high enough enough for it to be converted to the non-acid level, but not high enough to get the full combustion. So that's really helpful, and it has been shown to be more helpful for the lungs. And then there's also oil vape pens, and that's when they take the raw material, which is the flower, they do a full extract. Usually it's a CO2, compressed CO2 extraction. That's usually the safest and the one I usually recommend, but there are other options for the vape extraction. But again, this is what patients can use if they don't want to use raw flower, and they can really tailor it to the specific inhalation and dose they need. Now, inhalation is not really a method we recommend for patients. Inhalation that I've used with patients is really for breakthrough therapy. It's when they've been using cannabis to prevent pain, but they have breakthrough pain and they need something right now. Or somebody has nausea and vomiting and they were doing well, they were being able to avoid the nausea and vomiting, but all of a sudden they're about to, they have that sensation and they really need to stop it. Now, mind you, that's not the same thing as cannabis hyperemesis syndrome, which is the cannabis actually inducing the vomiting. These are two different things. Cannabis can be used for patients to to help with the sensation of nausea and vomiting, as long as it's, of course, not due to the cannabis. And also hyperemesis syndrome for cannabis is also actually very low. I believe it's still considered to be about 1% of the population. So it is not a very common thing that we are seeing, but it is something to to be aware of. And I'll go more into the side effects later on. For orals, this is really where our mainstay is for patients. They do use topicals. That's great, especially if a patient has pain and is worried about the systemic absorption, and also good, obviously, for veterans that are worried about getting tested for cannabis. So topicals are great, but sometimes they don't elicit as much of an effect as we would like. So then the patients could always use oral. We usually start with oils. Oils are usually a little bit easier. They call them tinctures, but truthfully, a tincture is alcohol-based. So I find alcohol-based tinctures to be a little bit faster acting. But most are oil-based. And the great thing about it is it's really helpful for dosing. It's a really great method because it comes in a vial, as you can see up here in the dropper. And it actually has demarcations of the different dosing. And it will say on the bottle how much you get per 1 milliliter. So the nice thing is you can start with a quarter, you can increase it to a half, so on and so forth, until you get the desired effect without having to take a full dose. Once I find that once a patient has gotten stable on an oral and we know exactly what dose to use, that's usually when I will recommend a capsule or edible. Could be because the patient doesn't really like the taste of the oil. And B is because a lot of times it's just easier, faster. They can just pop in a capsule, pop in an edible. Also, edibles in capsules, depending on how the oil is formulated, edibles and capsules might actually last longer in the body. So a lot of patients will use that to prevent the symptoms that they were having. There are also suppositories. Suppositories are really great for a couple reasons. If the patient does have nausea and vomiting, you can get the suppository, which will work pretty fast. And also, it does go directly into the systemic system as opposed to having to go through first pass effect when you use one of the oral methods. And just a little more about that, when you swallow cannabis, the first pass effect through the liver actually converts it to what's called 11-hydroxy THC, which is about 10 times as potent as regular THC. So we want to be very careful, obviously, with the orals because, again, it can be very strong. So with suppositories, it actually is similar to the inhalation route, where as long as you don't put the suppository in too deep, the majority of the suppository will actually get absorbed into the systemic circulation. So it's actually really effective to want to use a suppository, especially for nausea and vomiting, for pain, and also for locations such as the anal area or the vaginal area for different ailments, including pain during menstruation, or for patients who are. One of my patients is using it for his administration for his prostate cancer. Okay, so let's talk about why you would use one product versus another. The important thing about going through all of this is that often you will not get this information at a dispensary. Some dispensaries are great and will have this info, but the majority don't. So it's important to know what product to choose and why to choose that product. So for the slowest onset, longest acting products. So these are products I would say would be good for maintenance therapy. They usually work in about 1 to 2 hours. I say two because I like to go on the longer side of it just to make sure people don't redose too soon. And it lasts for about 5 to 8 hours. So really, again, this is for a long-term effect. Then the next, and this is usually our orals. We see this again in our edibles, our capsules, and stuff like that. With moderate onset, if you want something to work at about half hour to an hour, and it lasts about 2 to 5 hours, we're mostly seeing this with beverages as well as those fat-soluble tinctures, and also if you take a tincture with fatty food. Taking cannabis with fatty food will help with the absorption of the cannabis. So it is recommended that it can be taken on an empty stomach, but if the effect is not as if the effect does not come out the way that you want it to, instead of increasing the dose, you can always try to take it with a tablespoon of peanut butter or something, a teaspoon of peanut butter, or another type of fat to help the ingestion and absorption into the body. For fast onset, and back to moderate onset, and this is what we would use for patients knowing they're about to be in an experience that's going to cause pain or stress. Like, for example, if you're going to go work out, you'd probably want to take the moderate onset products. If you have anxiety, or if you know you're going to get triggered by something like PTSD for the veterans, you want to make sure that you're taking it. This is a product you would take before you know you were entering into one of those situations. Then for fast onset, these are really for things that we need effect right now. And that's exactly what I was mentioning before about the inhalation method, because the inhalation is pretty much right almost instantly. Some people can take up to 5 minutes, but that's very rare. We usually see almost an instant response, and it lasts for only about 1 to 2 hours. So this is usually for people currently experiencing something, and this is what they would use to relieve themselves for this type of experience. very fast. The biggest thing I also recommend when at a dispensary, you always want to look for what's called whole plant full spectrum products or extracts that the product was made from. What this means is that the entire cannabis plant was went through the extraction process and they extracted all the cannabinoids, all the polyphenols, terpenes, and everything else. And it's a fully like a full product, except that it doesn't have the flower. Guys, can you please make sure you guys keep yourself muted? Thanks so much. Um, so that's what we want to make sure. That's why whole plant full spectrum is so important to have. So because we make sure that it has all the cannabinoids. What we find when we have isolates, so just so you know, Marinol is a synthetic isolate of cannabis, and Epidiolex is a non-synthetic extraction of CBD dominant cannabis. But both are isolates for the most part. I mean, there is some terpenes that they did leave in the Epidiolex, but in general, it's not the whole plant for either med. And the reason that's an issue is because the new studies that have come out have actually shown you can use a lower dose and have a more effective benefit with the whole plant full spectrum as opposed to just the isolates alone. Okay, so here's some general advice for adults. So we got some basics. So as I said before, our biggest thing is start low, go slow, and stay on the lowest effective dose. And that's because a lot of people might say, I had this with some of my elderly patients. They've said, oh, I'm feeling great. Maybe we should do more because it'll be better. And I'm like, whoa, 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 whoa. If you're doing great, let's not touch it. You can only do so great. And then once you hit that great, you might come down the other end and not do so great. So it's important to stay on the lowest effective dose, especially because over time you might have to slowly increase the dose due to potential tolerance. I also always say that as a baseline, I personally, and I believe my colleague Paul as well would agree, we do not recommend to take more than 2.5 milligrams of THC per dose when starting medical cannabis therapy, unless you're working with a cannabis specialist who has recommended a higher dose. To be honest, for people who are cannabis naive, 2.5 milligrams can actually be pretty sedating. So you really want to be careful. I mean, for a lot of people who have used cannabis for a long period of time, 2.5 milligrams might do nothing for them. But especially for the new patients who are cannabis naive and just starting out, we want to, even if they've used it when they were younger, cannabis is different now and the orals are different. So we want to make sure that they are starting at 2.5 milligrams or less and that they wait a solid 2 hours before redosing. This is a problem I've had with a lot of my patients that I end up seeing because they come to me because they've gone to a dispensary and they were given a 10 milligram edible. They take the 10 milligram edible because they weren't given any instructions. They were told, take it for better sleep. They do that. And then about 30 minutes later, they say, well, I don't feel anything. I'll take another one. And then 30 minutes later, same thing. So now they've had 30 milligrams of THC and right at the hour mark is just when it starts kicking in and starts working. And then all of a sudden they go through a terrible time and have a horrible sense of paranoia. And some patients have even had to go to the hospital due to these side effects. So that's why it's so important to make sure that cannabis does not get started at more than 2.5 and that the patient wait at least they wait for 2 hours before taking another dose. If you get a gummy, most of them are either 5 or 10 milligrams. So a 5 milligram cut in half, 10 milligram cut in quarters. I've seen cannabis for patients as low as 0.5 milligrams be very effective and actually get a slight cannabis sensation without the euphoria, but also definitely feeling like something's in their system. So as low as 0.5 milligrams of THC can actually be quite effective for patients. Also, don't forget about CBD. CBD is also great for cannabis naive patients, especially for insomnia and also for anxiety. So, and anxiety and agitation is what we do see a lot in with dementia patients with dementia and Alzheimer's. So it is so a little bit of THC is actually quite helpful for them to help relax them, as well as having higher amounts of CBD also to help with the relaxation. Lastly, again, I mentioned the whole plant full spectrum products, and also the number one thing, you must avoid synthetics. I always recommend this because because the way that synthetic cannabis is made is it's actually through a chemically derived process. What they do is they take CBD flower, so CBD dominant cannabis flower, and what they do is they actually add heat and strong acids, which can be such as sulfuric acid, and then they let it sit. And what happens is over time, it converts the CBD to delta 9 THC and delta 9 to delta 8. Obviously, there's more that goes on there, but I just want to give a brief explanation of that. And the problem with synthetics is, again, they have this acid in there, and the people who are making it are not often people who are professionals, and they're not pharmaceutical companies. So I'm not saying pharma is great, but I am saying that at least pharmaceutical companies will test their product to make sure all of the solvent has been taken out so that the patient doesn't get any. Where with the synthetics that are sold in the market, such as Delta 8 THC, THCO, Special K, etc. You want to be, or I believe K Spice, I'm sorry, K Spice, and etc. You have to be very careful to make sure that they are not, that patients are not using these. I always tell patients, if you're in a location with a dispensary, to make sure to go to a dispensary, as they often will not carry these products. And I always tell patients, if you see Delta 8 THC, run and find a different place, because that is not a proper place to go. There are still studies being done on Delta 8 THC, but again, until we have proper research as well as proper manufacturing practices to make sure there's no harm to patients, I do not recommend any of these for the patients. Another thing with THCO, it was something that was derived and it was inhaled. And we saw the same issues with THCO as we did with the Avali epidemic, which is pretty much having vitamin E oil and acetate conversion, and it actually causes damage to the lungs. So it's important to understand why we're trying to avoid synthetics and why whole plant full spectrum is so important for our patients. So to get to the fun nitty gritty part of cannabis, there's a lot, of course, there's always adverse effects with any type of substance you take, even water you can overdose on, of course. With THC, the common ones are what you would expect. The patient might feel dizzy. If they take too high of a dose, they could feel a little high or euphoric. If they take too high of a dose, they might feel some anxiety, because cannabis does have a biphasic reaction where at low doses, you've got the anti-anxiety effect of THC, but at higher doses, you actually can induce anxiety, which is what was happening to all those patients that, took 10 to 30 milligrams of THC in one sitting and felt paranoid and felt they needed to go to the hospital. Of course, sleepiness is definitely common, and it's sleepiness kind of makes sense because usually we do use cannabis to help patients to fall asleep. So it is a side effect, but it also could be the point of why we're using it. And then in the same situation as any other medications that have this, like any sort of anticholinergic effect, meaning they'll have dry mouth, there is the potential for blurred vision, there is dizziness when standing, in general, a lot of drying effects that can lead to these ailments. There is also increased heart rate. This is so important to know for patients who have high blood pressure who do get started on cannabis, as there can be notice of change in the heart rate. And it's always important to let the doctor know that you will be using cannabis, as they need to monitor for these potential issues. For the uncommon ones, there is acute psychosis, paranoia reaction. As I said, my patient's experience. There is a chance that they could have a psychotic disorder, but only if they were predisposed. So similarly to when you see young men first experience having schizophrenia or psychotic disorders, that is when you're going to see most of the time it would be somebody also predisposed to it by having genetics often. Of course, insomnia, sometimes THC for some people can actually cause the opposite. It's not very common at all, but it is possible. There is anxiety that does happen, as I mentioned before. There's also cannabis use disorder and cannabis hyperemesis syndrome. So I'm going to go over those a little bit more, a little quickly. So cannabis use disorder is actually in the same realm as substance use disorder, and it is in the DSM-5 for these types of issues. However, cannabis use disorder really comes down to very similar to substance use disorder. You can't function, where you feel you must have it, where it affects your daily life in a negative way, so on and so forth. And then with depression, THC can cause depression, but also it can also help with symptoms of depression. So really with ailments such as depression and other neurological symptoms, really, I do recommend that you work with a medical cannabis expert on it, because these ailments can be exacerbated by the medicine as well. So it's important that we know that. And then with cannabis hyperemesis syndrome, as I mentioned, it is cyclical vomiting, which is actually induced by the use of cannabis. We've seen it for different people. They're still trying to figure out where it's really coming from. There is a question if it has to do with toxins or some sort of issues or some sort of synthetic product. But, really the jury's out right now, and we're still waiting for proper studies to really understand who develops it and why they're developing it. The biggest thing to know is it really is only 1% at this point that has been found to have actual cannabis hyperemesis syndrome. If you are a practitioner and you do work in a hospital system, it is important to know that pretty much a lot of hospital systems will say you have cannabis use disorder if you come into the ER with nausea and vomiting and have state that you use medical cannabis. They kind of just make that assumption, even though they don't really do the workup. So it is important when you see cannabis hyperemesis syndrome, take it at a grain of salt, unless you know from the patient that they definitely have cannabis hyperemesis syndrome. It's not for all patients, but another interesting aspect of it is that for cannabis hyperemesis syndrome specifically, a lot of patients do find relief from the cyclical vomiting with heat. And that's a huge indicator that it could be cannabis hyperemesis syndrome. They find that hot showers relieve the nausea and vomiting, and then that pretty much almost a few minutes after stepping out of the shower, they get the nausea and vomiting feeling back again. They also found that capsaicin topically has also been really effective for that nausea and vomiting sensation. But again, it's not a very common ailment, but it is something to look out for, and it is always a possibility with cannabis use. There is also a potential for stroke and secondary MI. More research is being done on this because how the research was done was not the best, because it's more retrospective. So it's important that we get more up-to-date studies prospectively to really study these patients to see what these actual outcomes and what the prevalence is as well. For CBD, sleepiness, and again, that's actually why we use CBD often for insomnia. But CBD for patients, especially those who have a high tolerance for THC, have actually been find that CBD actually might cause insomnia for them. So you really want to be careful with your patients, because you want to see how CBD works. But if they say they felt wired, we definitely want to come down on the CBD, because that could be keeping them awake at night. It does also have the potential to lead to decreased appetite, and due to the decreased appetite, weight loss. It's not seen too often, but it is something that is seen, and some patients actually like that side effect. And then diarrhea is actually common in the beginning. Not everybody has it, but I mean, but if they're going to have a side effect, diarrhea is a more common one. And again, it resolves usually with the use of the CBD and fiber. And then obviously people can be irritable, headaches, abdominal pain, but in general, these are just the most important things to know about adverse effects for your patients. And then interactions for our patients, as Dr. Lawful mentioned, there are so many interactions that could happen, not for cannabis, but due to the fact that the patient is on so many medications and has a lot of ailments. So for cannabis interactions, for THC, we always say be very careful with depressants. Depressants are examples like opioids or alcohol. And the reason you need to be careful is only because these actually will increase the sedation and drowsiness. So obviously, if you're already on something that can lead to sedation, drowsiness, we want to be very careful when adding other things that can cause sedation and drowsiness. I always recommend if I don't recommend alcohol be taken with cannabis. I actually just don't recommend alcohol. But if you do have a patient that you know is gung ho and they're going to use alcohol and they're going to use cannabis, we always recommend cannabis first, as the effects take longer to kick in than the alcohol does. So it's better to start with the cannabis, wait for, depending on how you take it, wait for the allotted time and then have your alcohol beverage if that's the direction you decide to go. If you go the other way, what we've seen is patients will use alcohol and then take an edible, and then an hour later are just so far gone that they didn't realize they would be that sedated. Again, you want to be careful with stimulants as well as the depressants because cannabis can increase the heart rate. So if you already are on a stimulant, be very careful to notice that THC will also increase the heart rate. Also for anti anesthesia meds, sorry. There is a decrease in effects of propofol specifically, but for the anesthetics, you really want to be careful because there is a high chance that it can decrease anesthetics and a higher dose might be needed. With my patients before any sort of surgery or anything, I always let them know, or any procedure, I always let them know, just like the doctor says, stop eating at a certain time. Really take your bedtime dose of cannabis, but don't take your morning cannabis, as it could cause an issue with surgery. And then and then obviously you want to make sure to let your doctor know so they check your levels, as THC and CBD can definitely affect your blood pressure and your blood sugar. I had a patient not a patient, I had a colleague whose wife was on CBG, works similarly to CBD, but it's not as promiscuous as Dr. Peterson likes to say. And with CBG, what happened was she was on insulin. She didn't tell her provider that she was on taking cannabis products, and she was still taking her normal dose of insulin, but she wasn't told to use it on a sliding scale. So the insulin she took literally plummeted her blood sugar, and her husband found her the next morning unresponsive. So it is very important that you speak to your medical professional, your primary care, about the use of cannabis. And if your provider does not support it and is against it, I always recommend to find a provider who does support the use. They don't necessarily have to know how to use it properly. They just have to know they should be monitoring you for your blood sugar and blood pressure to make sure there's no issues, along with your normal levels. Another thing would be warfarin. Warfarin, actually, with CBD and THC, it can increase the warfarin drug levels. The great thing about this, though, is you can just decrease the warfarin dose. Decrease the dose, decrease the drug levels, and everything's fine. So it's actually better because patients can be on lower doses of certain medications when they actually are using cannabis. Also, theophylline decreases the drug level, mostly inhaled, but again, it's not a very used drug at this point. And then for CBD, the biggest thing is it does increase the liver enzymes, especially with valproic acid. But valproic acid and even clobazam, which is used for epilepsy, both meds can actually they're both used for epilepsy. Valproic acid also has other uses. Both meds can actually increase when you monitor the levels, and if they go up, you can actually decrease both. So if clobazam levels are too high, you decrease the dose of clobazam. If valproic acid levels are too high, you decrease the level of valproic acid dose. And due to that, that will help to bring the levels back down to the proper range. And this helps, so lower drugs, less side effects, better for the patient anyway. And again, important thing to keep monitoring for those levels. There's also, lastly, there's also interactions with immunosuppressants, and which can increase the drug level in the body. So that's also important to know. So that was a lot in a very short time. Here are our references. And then here's some info, and please feel free to unmute yourself, ask questions, put them in the chat. I'm going to actually check the chat right now to see what there is. Unless, actually, does one of my fellow members want to check the chat for me for that? and let me know if there's anything. If not, we're good. But please feel free to ask questions, and floor is yours. And Paul's here too if you have questions for Paul.
Thank, thank you for all of that, Leia. It was definitely a lot, very comprehensive, specifically about our seniors. Like if you were gonna, try to get to the point of this talk, which was to, what do seniors need to know, or what are people taking care of seniors? What are 1, 2, and 3? Like, where are we at? I heard start low, go slow, and stop at the effective dose. That sounds like one of the 3. What are the other 2 things that people would be walking away from here if they're not sure which piece of information we shared? What should they walk away with?
Of course. So this slide was the most important, I would say, for advice for elderly. The start low, go slow, stay a lowest effective dose. The biggest one is not recommended to take more than 2.5 milligrams of THC per dose when starting. So that's one of the big things, is no more than 2.5 milligrams of THC. And to make sure that redosing is not within 2 hours. So I'd say I have 5. I have 4 big take homes: start low, go slow, and stay on lowest effective dose. Don't start any higher than 2.5 milligrams of THC, because doses as low as 0.5 can work and be effective. Wait at least 2 hours before redosing, and stay on whole plant full spectrum products for safety and avoid synthetics. So those are my big take homes. I'll leave this slide up. I hope you guys can still see it. But I will leave this slide up for so you guys can view it. But these are my big take homes. Really, it's low start, cut those 10 milligram gummies in quarters, cut those 5 milligram gummies in half, and wait at least 2 hours before taking a second gummy.
Yeah, I think of blood pressure. I didn't hear a whole lot of chat about it, but if you think about the medications, you talked about blood sugar, but
I said
blood
both.
pressure.
Yeah.
Yeah.
I said the reason it's important that when a patient uses medical cannabis is that they're working with their primary care, is so that the primary care monitors their blood pressure and blood sugar, as cannabis can reduce both of those. And so if they're already on a medication to reduce it, the medication might actually need to be reduced. So if the provider isn't informed and they're on something, let's say a beta blocker, and their blood pressure is slowly reducing, it could cause issues to stay on a higher dose when they should have that dose reduced. And that's why it's important to have the provider review for both blood pressure and blood sugar, to make sure that and also I always recommend to my patients, if you're on insulin or if you're on any sort of blood sugar medication, or if you have high blood pressure on a blood pressure medication, make sure to test yourself at least once a day, at least once a week if everything is controlled, just really to make sure that everything is staying in range. And if you're seeing levels go down, again, let your provider know, and the provider should be checking these as well.
Bingo, I agree. We got to empower our patients, especially in those conditions where we're going to have to titrate. And cannabis is vasoactive and probably affects blood sugar too. So I agree with your recommendations. Thank you, Dr. Johnson.
Of course. Thank you, Dr. Peterson. I appreciate the questions. Anybody else?
Cody?
Oh,
Are we echoing?
you're good now. I think Cody muted.
Okay. Cody, the point that I wanted to make was the frequency of dosing, particularly in the elderly. There is a incidence of about 3% of the elderly going to the ER because they have, quote, lost control. It has to do with the dosing frequency. And so the recommendation would be not to take this drug after an hour if you're not getting the effect that you want. I think it's a comparison between cannabis and alcohol. I think that the person who drinks alcohol might get an effect that they feel, if you will, within 30 minutes or 40 minutes. But with edible cannabis, it may take several hours to occur. So it's important that practitioners alert their patients to not trying to increase the dose by, or that they need to increase the frequency to avoid potential ER visits.
Exactly. And I've seen that too. Like that's what I've been seeing with my patients too, Paul, is just like you said, they lose control and they just feel like they're having a nervous breakdown, and a lot will go to the ER for that.
I would agree. And I think those are definitely the two main points, is to start low and not redose too quickly. And even the lowest dose might be 1 milligram. So you could cut a 5 in quarters or use an oil to really titrate down and start very low for someone who's cannabis naive.
Oh yeah. I mean, I truthfully start my patients on 0.5 THC. I don't start them at 2.5. It's because I personally think that dose is too high for starting, but it's at least a dose where they might get the euphoria without the paranoia. But I do agree with you, Jill. I would agree to start lower. I think 0.5 or 1 milligram is a good place to start.
And you know, this redosing too soon is not limited only to older adults. It's just that older adults tend to be a little more frail and a little more sensitive to those high dose effects. But even a physician whom I work with, a 40-year-old woman, was dealing with cannabis and took 10 milligrams and then took 10 milligrams more, and almost brought herself into the emergency department. So these problems, while they affect older adults and increasingly are affecting older adults in legal states, they're certainly not specific to older adults. So I appreciate that part of the talk as well.
Exactly. Great point. Did I miss any, the PCCC peeps, did I miss any questions in the chat? Just wanted to make sure I didn't miss any.
One question just came across is, does a THC/CBD nebulizer exist?
I feel like I just saw one coming on the market, but I think they're still in testing its effect. Have you seen one, Cody? I feel like I've seen one in development because I think somebody reached out to me about it, but it's definitely not common by any means.
So I've seen inhalers,
Yeah.
but I have not yet seen a nebulized version. So that would be this lipid THC would have to likely be suspended in a water base to be nebulized into the air. And I haven't seen it, but based on the fact that we deliver steroids in this way, I could see it happening. The question would become is, can we load enough cannabinoids into these nebulizers and deliver them effectively with those means? I'm not sure that we have gotten to the answer to that question yet.
True. And then also with nebulizers, again, that would be another treatment you would use for more immediate care and not long acting. So if somebody was having a breakthrough pain or breakthrough issue, I can definitely see the nebulizer. But for general ailments, especially pain and insomnia, you would go on the longer acting ones instead of the short acting.
Yeah, we've got vaporizers. I got to think that there's a very similar functionality going on. It's just a matter of what form the drug delivery is in and whether it makes sense to load these fat-soluble cannabinoids into water to then deliver them that way, as opposed to just delivering them as fat-soluble. So
Exactly.
I might be concerned about the contaminants in such a product and what the testing situation is. I mean,
That's
that
true.
would be my
That's a
issue.
good point, because it's not FDA reviewed, and since it's not, they're not monitoring it they wouldn't be able to monitor it for the same safety levels as normal nebulizers or inhalers. So I do remember seeing a lot of inhalers on the market before, but a lot of them have gone away. I wonder and I'm not exactly sure why, but I have noticed some have gone away. I think there's still a couple out there, but not as many as there used to be. Great question, though. Really, really great question. Especially because inhalation is hard for our elderly patients.
There's another question.
Okay.
It says, are topical options being promoted to the older populations to manage side effects?
So I mean, and Carrie knows a lot. Dr. Franson knows a lot about topicals. She had her student do a review on them. Um, I I personally haven't seen side effects with topicals, except for like skin ir like putting it on an area that you shouldn't put a topical, like on an open wound. You shouldn't do that, of course. But I haven't seen. I mean, usually what I see as side effects for topicals is issues with the carrier causing skin irritation, but not with the actual cannabinoids. But please, any of the other PCCC members, please jump in because I personally haven't seen side effects with topicals.
I think the question's addressing that exactly, that because there's less side effects, is that what you promote?
Oh.
And do you believe the topical can get the bioavailability, or can it get into the system as well as it needs to for treatment?
Thanks, Carrie, for clarifying. And the other thing we also have to think about for that is also like there are patches on the market. It depends on who you talk to. I don't think any blood levels have actually been tested for for systemic absorption in a patch. Which, yeah, I mean, a patch and a topical is not exactly the same, but they're kind of in the same boat. Topical alone, I haven't, I think that that's why people use it more often is because it is less likely to, really no studies have really shown it getting into the systemic circulation. With the patches, it depends on who you speak to. But in general, that is why they use it. And there could still be side effects, but more of a topical effect as opposed to a systemic effect. Like, in other words, if you're trying to avoid drug testing, as long as you're not putting the cannabis product in an area where it would come out through your drug test, like if it's on your hands and you're holding the cup, for example, and it somehow gets contaminated. But in general, if you're putting topical outside the body, it shouldn't be able to be systemically absorbed, so it shouldn't be able to be to pop up on a drug test. Suppositories still might, or suppositories will, but topicals usually won't. Anybody else? Or anything you want to add in, Dr. Laughlin?
Well, when you talk about topicals, in general, they don't get absorbed as well as other administration forms. However, since the cannabinoids are lipid soluble, they're more likely to get absorbed than a water soluble drug. So to that extent, we could expect to find some blood level there after topical administration. And the other question would be, okay, is there a chronic effect? Well, we know that the active metabolite goes away pretty quickly in a couple of hours, as opposed to the old blood or detection methods, which was inactive. So I think there's a potential use for that, but it'd be more difficult to dose than normal. Let's put it that way. From the inhalation point of view, certainly a nebulization formulation could be made that does not necessarily have to be in water, or if it was in water, it would need to be potentiated or have some kind of help in absorption using some type of surfactant to get the drug in the system. But if you look at the inhalation or the vaping side, certainly it's an effective way to get drug in the body. And it would be just a matter of formulating it to make it work. Patch is a little bit more difficult because of the sort of the chemistry that's involved with that. And so you can't just put an ointment or a cream on a gauze pad and put it on your skin and call it a patch. It just doesn't work that way.
Leah, you're on mute.
Of course, I'm on mute. Thank you, Jill. Okay, so Paul, this goes to you. So for in terms of having a panic attack, a patient took a benzo to counteract it. In case of emergency, would that be something to recommend? And Roman, I'm guessing you're saying to recommend the inhalation cannabis instead of the benzo? Think. If that's what you're asking, so the problem with using inhaled cannabis for panic, in case they took
Leah,
too.
I think he's talking, my interpretation is that if they took too much THC,
Oh,
is it wise to take alprazolam,
oh, so
counteract that?
I would say no, because it's a sedative. So you've caused panic attack, but now you're gonna add. So you've got one sedative, and now you're gonna add another sedative. It just more drugs doesn't always solve the problem. The best thing is to, if you take too much edibles and it does trigger it, the best thing to do is to have the patient pretty much go rest. Sadly, I usually say similarly to what we say for alcohol, make sure they're in a safe place, make sure, I always put sensory deprivation to like relax the sensation of the bright lights or the bright noise, loud noises. I personally wouldn't recommend it because again, I don't like to add medication due to a medication side effect. But that's just my 2 cents. Anybody else, please feel free to jump in.
So I mean, I'm certainly not going to advise patients to be taking Xanax. However, if a patient came in having a panic attack to the emergency department, I can basically assure you that I would give them a benzodiazepine. And from a respiratory depression and overall sedation perspective, because of THC's mechanism in the endocannabinoid system, we don't have a profound decrease in drive or wakefulness. So in general, overdoses are still unlikely with even that combination. Now, to get to more of, I think, the point is, most of the time it's an anxiety related issue. It's sort of like your fight or flight system running away. So fresh air, a cool sugary beverage can be helpful. Music can be helpful. A change of setting can be really beneficial. It's really going to depend on the predictability of the person you're with, whether they're having a fight and flight moment and you cannot talk them down, or if they're just having trouble catching their breath and they're able to do it. So, it's so hard to paint with broad brushes like that. But certainly I'm not going to recommend patients be taking Xanax regularly, but I will just say that that would be the treatment of choice in an emergency department.
Yeah, agreed. In an emergency department setting, that is, yes.
I got to run, y'all. Appreciate everybody.
Thanks
Bye.
for being here, Cody. Have a good one. All right, any last questions? If not, we'll close for today. Oh, thanks so much, Roman. Happy to help. If for anybody who's interested in seeing this, for those who are on, you can let your colleagues or friends or family know to look us up at www.pcccrx.org. And that's where all of our recordings, including this one, will be, and all our past recordings on the use of medical cannabis. So thank you all for coming, and on behalf of PCCC, we hope to see you next time.